Hello and welcome to CaringKind. My name is Adina Siegel. I am a social worker here at CaringKind. CaringKind was founded in 1978 by a group of family caregivers. We were formerly the New York City chapter of the Alzheimer's Association. In December 2015, we left the Alzheimer's Association and returned to our roots as a local nonprofit organization serving New Yorkers affected by dementia. CaringKind is the only organization in New York City focused solely and exclusively on care and support for people with dementia and their caregivers. We serve all 5 boroughs and all our programs are free of charge. All donations received stay right here in New York City to support people affected by dementia. We have several programs available. I will be speaking about them later on. I would request that if there are any questions from any of our listeners to please call our helpline at 646-744-2900. We have staff available to help you understand the different diseases that cause dementia and how best to care for people who are affected, how to get support for yourself and other things. So please do not hesitate to give us a call. So on our agenda for today, we're going to discuss what dementia is, normal aging versus dementia, how it's diagnosed, what Alzheimer's disease is in particular, with some statistics, pathology, and stages. We're going to discuss other common causes of dementia, the medications available, what you can do as a caregiver as well. So dementia is actually a group of symptoms that result from an underlying medical condition. It is not the medical condition itself, and it affects 4 areas of functioning. It affects memory. Short-term is always affected before long-term. It affects cognition, thinking, planning, reasoning, logic, making good decisions, those things. Behavior, such as mood and personality. Somebody who is very introverted may suddenly become really extroverted and vice versa. Somebody who is really nice may become really mean. Sometimes somebody who becomes really mean can become really nice. But it's definitely there can be massive changes in behavior, and it does affect physical functioning. After all, it is a disease process, and motor skills and gait get affected at first. A lot of times fine motor skills are affected. It will eventually lead to difficulties with balance and walking, and in the later stages, unfortunately, it affects autonomic processes like swallowing and even breathing. If it gets to that point, organs do eventually shut down. Now, I get this a lot where people ask, what's the difference between dementia and Alzheimer's? Or, well, my loved one only has dementia. Luckily, they don't have Alzheimer's. And I think it's important to kind of clarify what exactly dementia is versus Alzheimer's. So dementia is the umbrella term, hence we have the umbrella on the slide. And we have also different types of dementia. So think about it like soup, right? You have different types of soup. You have onion soup, you have tomato soup, you might have chowder, you can have all sorts of different soups. So it's the same idea. You have all different types of dementia. So Alzheimer's disease is actually the #1 form of irreversible dementia. After that, we have vascular dementia, which is caused by mini strokes in the brain. Lewy body dementia, which is a form of dementia that has a lot of Parkinson's symptoms with it. Frontotemporal dementia, which affects language and behavior. And a lot of times, dementia can be mixed. In fact, now I think the current scientific understanding is that very few people with dementia only have one type of dementia. A lot of times there is a mixture of the different causes of dementia. I do think it is very important to mention, though, that there are reversible forms of dementia. So certain vitamin deficiencies can contribute to dementia and cause dementia. Urinary tract infections can both create dementia symptoms and also actually exacerbate dementia symptoms. So I think what's incredibly important, even if somebody has an irreversible dementia, is if there is ever a very sudden change in behavior, it is very important to get them to the doctor to rule out a urinary tract infection, because that often happens. Older people do not experience urinary tract infections in the same way that younger people do. They may not feel it. It may affect their cognition. So it is very important to be mindful of that. Depression is another rule out for dementia. There is a lot of overlap with symptoms of depression and dementia. The difference is if somebody has depression, then treating the symptoms treating the depression will get rid of the symptoms. Whereas if you treat the depression and they still have symptoms, then the symptoms are caused by dementia. Okay. And now I think, especially when you're around people who have dementia, you start worrying about yourself. So what is the difference between normal aging and dementia? So we all occasionally misplace our keys. If we forget how to use a key, that is a cause of concern and important to get a diagnosis, to get a rule out of a diagnosis of dementia, or to get a diagnosis of dementia. We all forget the right word from time to time, but when you have difficulty following a conversation, that's a sign of dementia. Not being able to complete sentences can be a sign of dementia. We all temporarily forget the day. Particularly on January 2nd, we probably even forget the year. That is normal. If we lose track of the date and the season, and you start wearing shorts when there's a snowstorm outside, or wearing a coat when it's 90 degrees, that's a sign of dementia. Now, when you are concerned about somebody who has dementia, it's highly, highly important to get a proper diagnosis. We recommend a formal diagnostic evaluation that's performed by a multidisciplinary team of doctors and healthcare professionals in hospitals and medical schools. It is much more thorough, and they will do a formal diagnostic evaluation, which will consist of a family history. They'll take a physical exam and blood tests. They're going to want to rule out all the irreversible causes of dementia that I mentioned. They're going to do neuropsychological testing for memory, cognition, and personality. The most famous ones are the clock test, where they will actually have a person draw a clock and put it at 3:30, an analog clock. A lot of times, it sounds simple. A lot of times when people have dementia, they are not able to do it. They're not able to put the visuospatial components together, and they're also not able to have the symbolic reasoning to realize that 3:30, you put the small hand on the 3 and the big hand on the 6, and the 6 equals 30. So it gives a good window into where the person is functioning cognitively. They will also do different word recall tests, where they'll give somewhere between 3 to 5 words to a person, have them memorize it, distract them, and then 5 minutes later ask them to repeat the words. The doctors will also probably do brain imaging. There are PET scans and MRI scans, and they are going to be looking for different markers indicating some form of dementia. This whole process has a 90 to 95% accuracy, which is a very high degree of accuracy. The way to get 100% accuracy would be by having an autopsy, which cannot be done in a live person. So this is the best that we have, but it is highly accurate. So we highly recommend people go to centers for memory clinics in the area to get their diagnoses done, and it's pretty definitive. A lot of people might ask, what's the purpose of a diagnosis? There's not much that can be done anyway. Well, as I mentioned, you can determine whether a patient has a reversible form of dementia, something that can be treated. You can also see if there are medical conditions that are exacerbating dementia symptoms. So depression is one of them. Anything related to cardiac health is something of concern, and that can and probably will exacerbate dementia. So it is important to keep blood pressure down and to keep heart healthy as possible. Diabetes is another concern that can exacerbate dementia. So these are all things that you want to know and treat even with a diagnosis of dementia, because it will impact the dementia. You can also determine whether a person is a candidate for medications that help with functionality. I'm going to say this later on, but I feel like it's really important to speak with a neurologist about whether medications are the right fit for the person you're caring for, because there are certain considerations that need to be taken into account. And it also, but most importantly, it allows for planning. In order for a person to get the care that they want and to have their wishes honored, they really need to know what the prognosis is and be able to have a plan. And having a clear diagnosis can help a person formulate a plan. We're here to help them with that. And so it is something that is valuable. So some statistics, just to show how important this issue of dementia is to America. Over 5.7 million Americans live with Alzheimer's. Every 65 seconds, an American develops Alzheimer's disease. 1 in 10 people age 65 and older have Alzheimer's, and Alzheimer's is the 6th leading cause of death. This actually, it may be more conservative than what is actually the case, because oftentimes causes of death are determined by what is written on a death certificate. So if somebody has pneumonia, they are going to put the cause of death as pneumonia instead of aspirative pneumonia as secondary to Alzheimer's. So there actually may be far more people who have Alzheimer's as the main cause of death, but it is not being tracked. So it actually may be a higher cause of death in this country. By 2050, if nothing is done, approximately 14 million Americans will have Alzheimer's disease, and 1 in 5 New Yorkers will either have or be caring for someone who has Alzheimer's disease. So this it is certainly affecting a lot of people now, and it's going to affect a lot more people. That is why we bring these statistics in, to really highlight the importance of these issues, and that a lot of people are affected by this, and it is something that really needs to be paid attention to. So what is Alzheimer's disease? So Alzheimer's pathology consists of plaques and tangles. So plaques are abnormal clusters of the protein beta amyloid, which builds up between the nerve cells and leads to cell death. If you look at the picture, those little like pinky clumps are amyloid plaques. And amyloid actually happens in everybody's brain. When it comes to people with Alzheimer's, for some reason, they clump. And if you see, they're right next to the nerve cell. That big yellow thing is a nerve cell. And the nerve cell is supposed to be sending out messages to the next nerve cell. The problem is, with these plaques in the way, it can't do its job. And eventually, if a nerve cell is not able to do its job by conveying the message, the cell will die. On top of that, you have tangles, which are those neurofibrillary tangles inside of the cell. And those are strands of protein called tau, which are essential for maintaining the cell structure. And for some reason, which they're still trying to figure out, they collapse, and it leads to cell deaths and destruction. So you're basically having cell destruction from both within and without. And what basically we're seeing is basically parts of the brain which are dying in a person with Alzheimer's. So risk factors. There may sometimes be a hereditary or genetic factor that affects risks of Alzheimer's, but in the main, age is a risk factor. If somebody is 65 or older, they have a higher risk. That being said, that doesn't mean that it is a definite. There are things that you can modify with risk, but it tends to happen in people over the age of 65. Only about 10% of people are younger than 65 who have it. Race is another factor. African Americans have twice the risk, and Latinos are 1.5 times the risk. Gender is a factor. Women get it more than men. Oftentimes I've heard people say that, oh, well, it makes sense because women live longer, but actually current research has been showing that there may be more to it than just there are more women who live in older age than men, and there actually may be some either hormonal components or something related to you know, the biology of women that are affecting the dementia. Down syndrome is another risk factor. They are greatly increased risk of developing a type of dementia that's either the same or very similar to Alzheimer's. Family history, you can usually see it in several generations of a family. That is to say, though, it doesn't necessarily mean it is going to happen. There is a subgroup of people with earlier onset Alzheimer's who may have a more genetic component to it. There's the APO3 and a couple of other genes that have been highly associated with Alzheimer's. But for the most part, if you don't see like a whole cluster of people who are younger having dementia or Alzheimer's, they're not, it's certainly a risk factor. It's not necessarily a guarantee. For those subset of people who may have a more genetic component, it is usually recommended to see a genetic counselor about that to just get a clarity on what the risk actually is for them. Head injury is another big risk factor. Severe head injuries, meaning someone who's been knocked out for more than 30 minutes, have an increased risk. If they have repeated mild head injuries, they also may have future problems with thinking and reasoning. And as I mentioned before, the heart-brain connection. Poor heart health may lead to an increased risk of cardiovascular events, such as heart attacks or other issues, like high cholesterol or hypertension, and over time can result in changes to the brain, including strokes, which can definitely cause dementia. You know, one thing, as also I will be pointing out later on, in lieu of having, you know, cures, the one thing that scientists are saying and researchers are saying is that what's good for the heart is good for the brain, and anything you can do to take care of your heart will be helpful in caring for your brain. Okay. So for our purposes, we talk about mild cognitive impairment and 3 stages of dementia. Remember that these stages are not necessarily clear-cut, and a person can actually straddle between the two, and there may be overlapping in some of the symptoms. Also, it's important to keep in mind that each individual with Alzheimer's disease is unique and will go through the disease process in a unique way. So if you see one person with Alzheimer's, you see one person with Alzheimer's. So mild cognitive impairment is kind of a pre-Alzheimer's diagnosis. You'll have a person who has that they may have problems with memory and thinking that other people might notice, and they may notice. It's not severe enough to interfere with their independence, and it increases the risk of developing Alzheimer's disease. Most of the people who get it do eventually go on to develop Alzheimer's disease. I have also seen that sometimes people are diagnosed with mild cognitive impairment when they may actually be in the early stage of Alzheimer's. So again, it's important to kind of take mild cognitive impairment a diagnosis of mild cognitive impairment pretty seriously. But let's say once mild cognitive impairment goes on to early stage, you'll see a much greater degree of short-term memory loss. You know, not really remembering like a conversation that they just had 5 minutes ago. Confusion and orientation to place and time. They might get lost in places that they have gone to for 20 years. And they may also lose track of time. They may think that it's, you know, wake up at 3 o'clock in the morning and then, you know, expect that it's time for breakfast and getting ready to go to work, not realizing that it's actually midnight, in the middle of the night. Inability to follow complex instructions. Problems with money. Problems with money actually tends to be what makes families realize that there is a problem and that they do need help. You'll have people who may forget to pay their bills, or they may pay their bills several different times and then find that they have no money in the bank. You'll find a loss of initiative and motivation, where they just they're just apathetic and don't really want to get out of bed. It can be confused with depression sometimes. And it is important to kind of tease that out, because it could be that they're feeling depressed because they realize that there are changes going on, and especially if they know that they have a dementia diagnosis, but they're also maybe the part of the brain that is affected may be the part that is the get up and go part of the brain that contributes to our initiative and beginning a task, and that may just not be there anymore. They may have difficulty, they will have difficulty performing regular tasks. Cooking can be a problem. Difficulty learning new things, routine, people. Using the remote might be something really complicated for them. You know, any sort of new gadget or new person or new experience might be difficult for them to navigate. And we also see poor judgment. And this can also be connected to problems with money. This is where people are particularly susceptible to scams. And you know, it will make sense if they receive a call and somebody says, well, if you give me $500, then you'll win a $200,000 sweepstake. And you know, because of the dementia process, that will make sense to them, and they engage in with the scammer. And that can be a really, really difficult thing, particularly because at this point, they still have capacity and can still make poor decisions, but it often will leave families in very difficult situations, as we will see in our next slide, because we want to, while there are certainly deficits that due to the dementia, we do want to still consider that these are whole people and they can still do things. A person at this stage can still understand the implication of their illness. They can still participate in decision making. This is the time to start talking about advanced directives, to talk about getting a power of attorney, and to talk about setting up healthcare proxies and living wills. This is the time when a person, as disempowering as a dementia diagnosis can be, what they can do is set themselves up so that what they want to happen can happen, by making sure that they have, you know, people in their lives who can fulfill or be agents of their wishes, and make sure that they can make financial decisions that they want them to, and that they know what they want in terms of their health care. Leaving it and not talking about it often leaves things in a crisis and can be actually very disempowering. And so whenever I counsel families and people who have been newly diagnosed with early stage dementia, I often point out that this is the way you can empower yourself. Person can also identify and articulate feelings still in this stage, and it is important to talk about that if they are interested in doing that and are comfortable doing that. And they can still live pretty independently. Our concerns are always about their autonomy, their self-esteem, and their dignity. You know, a lot of times, particularly when, I mean, I've seen this in people who ended up being affected by scammers. You know, they want the autonomy to make the decisions that they want, even if they're bad decisions. You know, they don't throw, you know, it's like, don't throw me a life preserver unless I ask for one. You know, self-esteem is the desire to be seen as a person living with this disease, as opposed to a patient. You know, we in professionally anyway, we and I think really in a person's personal life, it should be seen this way. Also, we don't talk about someone with dementia as demented, or, you know, or a dementia patient. It's a person with dementia. The most important thing is this is a person. And, you know, people know when they are treated as a person versus when they are treated as a patient. And a lot of times you may see a negative reaction well, I think most people would have a negative reaction, but certainly you see it with people who have been diagnosed with dementia. They have very negative reactions to being treated as a dementia patient. And it can be particularly difficult to strike a balance between, you know, honoring the person's autonomy and you know, at the same time keeping them safe. And also, this is going to be another plug for our helpline. We do this type of work all the time in counseling caregivers, and I highly recommend if you're finding a struggle, that you're struggling with this, please give us a call about that, and we can counsel and help you. So we go on to the middle stage. So the approximate length of this stage is 2 to 10 years. During this stage, individuals need assistance and guidance. A lot of times they can't be living at home anymore. They shouldn't be living at home. You'll see an increased memory loss with more confusion than you saw in the earlier stages. Difficulty thinking logically and organizing thoughts. You know, they may not really be able to follow a conversation. Problems with recognition. They may not recognize people anymore. Or misrecognize people, thinking like, you know, their daughter is their sister. Increased communication difficulties. You may see that this is the time when they really can't complete a sentence when they're trying to explain themselves. Mood swings occur at this point, or you know, personality changes. Hallucinations and delusions often happen at this point, and you see this a lot with sundowning. Sundowning is what happens around mid to late afternoon. People with dementia can start feeling agitated or restless. A lot of times that is when they start hallucinating or having, you know, delusions. One very common delusion that I come across with a lot of people who feel that they need to go home, yet they are home. They may even tell you the address of where they are right now, but they will say that they need to go home. Others may think they're at work, and so why aren't you letting me go home? Or why aren't you letting me go to work? So it can get very difficult because they lose that orientation to time and to place, and it can require a lot of working with them and managing them to keep them safe and comfortable at the same time. Unfortunately, when it comes to dementia, the dementia always wins. You can't rationalize a person out of the delusion that they have due to dementia, and you kind of have to go with them in their reality, which oftentimes may mean, you know, I had one client who had a parent who thought she kept having to go to work, and the caregiver, who was the daughter, would say, well, Mom, you can't go to work, your hair is not done. And she knew her mom was a very vain person, and she realized her hair wasn't done, so she would be able to buy time to get her mother to, I guess, be distracted and forget about needing to go to work for a while. So sometimes you really have to enter into their world to keep them safe and comfortable. We also see motor problems, or the beginning of motor problems, particularly like balance. There may be concerns about falls. Incontinence, either because they can't manage in the bathroom anymore in terms of knowing what all the steps are and keeping themselves clean, or forgetting to use the bathroom in time, or missing the cues. So that can often be a problem, and you may have to introduce incontinence supplies. And the other concern is wandering, especially given that they lose their bearings and their orientation to time and place. It is very common that, you know, in the quest to go home, they will actually go out the door and start wandering. And we at CaringKind have a wanderer safety program with a bracelet that actually has a person's demographic information on it, with a tracking number, which is with Medic Alert. And we, when somebody is missing, they can call us, they can call first responders, and once that person is found, it'll be much easier to get them back to their home and back to their caregiver than if there is nothing there. A lot of times those are the cases you may see in the news where people end up in a hospital nobody knows who they are, and they may have pictures like, do you know this person? Does anybody know this person? So we want to prevent that as much as possible. So again, if anybody is interested in hearing more about our Wanderer Safety Program, again, please call the helpline. I will be giving the number at the end of this presentation. But just like in the early stage, the middle stage, there are still considerations that we want to think about in terms of what a person still can do. And people can still participate in modified activities. There are programs for people with dementia. There are a few that are available in the city. We actually have one here at CaringKind. It's called Beginnings. And this is where people with dementia can participate in different activities. A lot of them are either art or music or movement, but a lot of times it's what we want to create with people at this stage are fail-free activities. Basically, everything is all about the process, all about just engaging and forgetting about what the finished product is. And in fact, in some programs I've seen in my profession, there's something called time slips, where you'll have a circle of people, and each person will give a sentence. They don't have to correlate with anything, but everybody gives a sentence. There's a leader who writes it down, and then they read the sentence out loud. The sentence is out loud, and it's this funny story, and everybody gets a good laugh out of it. And it's really just about appreciating the process rather than about appreciating the finished product, which is a very important thing. They also have the ability to still choose, and I guess the key word here is modified choice, because a lot of times they will have difficulty making full-on choices in terms of, say, what to wear in the morning. You or I may think that it's really not that complicated to figure out what to wear in the morning. However, a person with dementia is going to have a very difficult time, because you have to figure out what's weather appropriate, what matches, what's a top and what's a bottom. And that can be really taxing to somebody who is affected by dementia. So you really want to do is kind of lay out maybe 2 different outfits that a person can wear and say, okay, would you like to wear the red outfit or the blue outfit? And this way the person still feels like they have a degree of choice in their life, and nothing it's not just being dictated to them. At the same time, they're not overwhelmed with having to choose something which their brain can't process enough of. So that's another reason why sometimes you have people who will wear the same exact clothing all the time. There are a couple of different reasons, but that could be one of them. And so it is important to kind of try to figure out modified choices for the person, similar to outfits, food, all sorts of things like that. But with the abilities, we still do have concerns to keep in mind. Loss of control. They might not be able to control themselves anymore. They certainly can't control their environment, which also leads back to the importance of being able to give them modified choices. Fear of abandonment. Here you will actually see a lot of separation anxiety. This is where caregivers might call to complain that the person is always following them, because they have lost the ability for object permanence, which is something we all get in toddlerhood, where we know that if the person leaves the room, they're still here. They didn't just leave and will forever be gone. Unfortunately, when somebody is in the middle stage of dementia, they lose that capacity. So if you're leaving, you may leave forever, and I will never see you again, and I need you. And so then how is that going to, affect me? So there, you will see a lot of separation anxiety. They need a lot of reassurance and being, making sure that they know that they are taken care of. That is another task at this stage. A lot of times they will be frustrated. They are losing their language capacity. They can no longer express themselves in the ways that they have all their lives. So a lot of times they will lash out in anger. And we have to really see that whatever is considered like a difficult behavior is actually a form of communication. And the question a caregiver has to ask themselves is, what are they communicating to me by this behavior? And our main concern, I think, is also safety. A lot of them, most of the time, they're no longer able to live alone anymore, or they may need 24-hour care. So that's another consideration as caregivers that we have to think about. So in the late stage, which lasts about approximately 1 to 7 years, here people are completely dependent for others on for their care. You will have limited verbal communication, minimal recognition of family or self. They're more sedentary and eventually become bedbound. Here we'll have the eating difficulties, like I mentioned, aspirative pneumonia. People lose the ability to swallow, and so as a result, food goes down the wrong pipe, and they can be susceptible to pneumonia. At this point, there's total incontinence and really no capacity for self-care. The vast majority of people in this stage end up needing nursing home care. A lot of times people might promise the person they're caring for that they'll never place them in a nursing home. And this promise can usually be translated into a promise to always ensure that the person is getting the care they need and deserve. Placement can be the only safe way to care for someone with dementia, depending on their needs and situation. So it is something to really think about, because I know that I come across this a lot in talking to caregivers, but a lot of times in order to have proper care, nursing home care is what's needed. Also, I do think it's important to realize as caregivers that just because you have to put a loved one in a nursing home doesn't mean that your job is over, and sometimes it means it's only begun. So, you're not necessarily abandoning your loved one by putting them in a nursing home. Many times they need this care, and some actually can do better with it because they have that 24-hour staff that they will not have at home. So even in this stage, though, there are things that a person with dementia still has. They still have the awareness of their surroundings. So it is still important to not speak about them in front of them, and to try to keep things, calm and secure for them. Here, even though they may not be able to participate in a lot, they still benefit from sensory stimulation. So still talk to them, even if they're not necessarily showing any signs of registering. There's still benefit to them hearing you. Music is also something that is very helpful, and touch is also something that they really can benefit from. Sometimes people will also say, like, using aromatherapy, but all sorts of sensory things, not necessarily verbal or logical things, but things that are just that can be experienced, they can still appreciate. And our concerns at this point are their comfort and their dignity. So here are some other common types of irreversible dementias. Lewy body dementia is the second most common cause of dementia. And here you have memory and thinking problems that are similar to Alzheimer's disease, but you will also have in the early part of the disease, you'll see Parkinsonian-like symptoms. So you'll see sleep disturbances, visual hallucinations, tremors, and muscle rigidity. So that's something to bear in mind. I have also just found that a lot of times it can be confused with Parkinson's. So you may have somebody who was first diagnosed with Parkinson's and then they end up with Lewy body. Sometimes people with Lewy body end up diagnosed with Parkinson's. So, it can often be a bit of a fluid diagnostic process, but it is important to know about that. Another common form is vascular dementia, and that's where you have microscopic bleeding or blood vessel blockages, which cause a loss of blood and oxygen to brain cells. And the location of the injury determines the changes in functioning, but the initial symptoms will often include impaired judgment or the ability to plan. Here also, it's the course of the disease here is different than other forms of dementia, because other forms of dementia, it's kind of a steady decline. And with vascular dementia, because it's dependent on TIAs or other cardiac events, you can have like a decline and then a plateau, and then a decline and then a plateau, and then a decline and then a plateau. So and here really the treatment is to kind of try to control heart health and vascular issues. So there may be some more things that might be able to be done to at least try to prevent further decline. Frontotemporal dementia has a number of different diseases. Typical symptoms include changes in personality and behavior and difficulty with language. People with FTDs generally develop symptoms at a younger age and survive for fewer years than those with Alzheimer's disease. And then you have mixed dementia, which has the characteristics of more than one dementia that occurs simultaneously. So here are the medications that are currently available. These medications manage symptoms, but they do not modify the disease. They're not going to change the course of illness. You still have to realize that Alzheimer's disease is progressive and there is still no cure. These drugs work in about 50% of the people who try them and can sometimes have very severe side effects, usually gastrointestinal, and people cannot tolerate them. So the ones that are available are, and all of these drugs, I believe, affect the beta amyloid plaques. So you have the cholinesterase inhibitors, which are Aricept, Exelon, and Razidine. For those who are, who are looking into medications, and maybe if there are issues around taking an oral medication, Exelon is in a patch, so that can be an important thing for some people. And then you have Namenda, which is a glutamate pathway modifier. And then there's the combination therapy, Namzaric, which is both donepezil and memantidine, which is the combination of like Aricept and Namenda. So what you can do, slow down and allow more time for activity. You may also want to give yourself more time. If you are taking care of somebody and you need to get them to a doctor's appointment, maybe tell them the doctor's appointment is an hour earlier to allow for more time to prepare. Adjust expectations. Realize that there are real cognitive issues that are not going to go away, and so maybe you have to modify things and expectations about what this person can do. Keep things simple. Don't give too much information. Keep things short and simple with few distractions. Don't talk to them when the TV is on or any other kind of visual distraction is on. I actually had a client who was taking care of her mother, and the mother was having trouble because she, it used to be that the family would come for, I don't know, like Thanksgiving or something, and she'd be able to kind of be, chopping carrots or something for whatever it was she was making and talk to family members at the same time. But now that she has Alzheimer's, she can't do two things at the same time. She can't talk to somebody and engage in an activity at the same time. So keep that in mind, that maybe really try to allow them to do one thing at a time. Don't argue, empathize, and then redirect. You really want to try to stay with the feelings that they're experiencing, which will help you to redirect them a little bit better. Remember that behavior is communication. Realize that the person with dementia cannot change, only we can change, and we have to. And there's no cure but good care, and we're here to help you with that. So as I mentioned, we have several different programs at CaringKind to help caregivers. We have a 24-hour helpline, which is, as I said, the number 646-744-2900. Please feel free to follow up on anything I have said, or if you have a specific question or issue that you would like to have a consultation about, please feel free to give us a call. We provide social work services. We have support groups for caregivers. We do education and training, including training for home care workers. So if, let's say, you have an aide that you like, but the aide could use some more training and understanding how their patient is affected by dementia, definitely have them give us a call. As I mentioned, we have a Wanderer safety program with the bracelet through Medical Alert. We also have Connect to Culture, which is a program to have people with dementia and their family and their caregivers go to museums where there is dementia-friendly programming. So also, if you have any questions about that or would like more information, please call our number. We also have for persons with dementia, we have a day program. It is called Beginnings. And again, if you're interested in finding out more information, please call our helpline. So as caregivers, there are a bunch of things we really need to remember. Your feelings are normal, and really any feeling that a caregiver is feeling is normal, from anger to guilt to frustration. There also can be some positive, surprisingly positive feelings you might feel, maybe not, but really the whole picture of caregiving is so difficult and complex and conjures up so many feelings that there really is no one normal way to be. So any way that you are feeling is normal. But I think the most important takeaway is that you cannot do this alone. You really need support. The other thing to consider, to realize, is that, you know, do the best you can. There's no such thing as perfect, right? For those of you who are familiar with parenting, you know, there's no such thing as a perfect parent. There's a good enough parent. It's important to realize there's no such thing as a perfect caregiver. There's a good enough caregiver, and that is good enough. You want to, and again, we're here to help you. Please, please give us a call if there's anything we can do to assist you. We really will do our best to do so.